So thanks everyone for tuning in. Happy Halloween. It's the day after Halloween in Australia at the moment. In fact, we have a public holiday for a horse race today called the Melbourne Cup, which is our version of the Kentucky Derby. But more importantly, today we're very grateful for the team from University of Chicago to host us. A quick fun fact about Chicago is that it's the city where spray paint was invented, which was interesting, particularly, I guess, during Halloween. It might be quite appropriate. Next slide, please. So this is us. Very grateful for the team. Obviously, Dr. Galandiak is overlooking all of this, and she always tunes in, which is fantastic. Next slide, please. This is just our disclaimer. Next slide, please. So Dr. Hyman initially approached us after one of the editorial board meetings, and subsequently I have been liaising with Dr. Authoritative. I hope I didn't mispronounce it too much, and Dr. Alverdy obviously as well, and I'm indebted to both of them for tuning in. Kinga is the assistant professor of surgery in the department, and I would be grateful if she just briefly talks about her city, her institution, and her colleagues on the panel. So thank you.
Yeah, thank you so much for the introduction. The last name is new for me too, is my married name. It used to be Scourin, but I think as far as I know, I'm the only Kinga in the colorectal world. I know that you had another journal club from our city earlier, so you've heard about Chicago a little bit already. And I like the factoids. There's a couple other interesting things that have come out of Chicago, including the Ferris wheel and Cracker Jacks, all that came from the World's Fair when we hosted it over 100 years ago now. But, you know, obviously we're known as the Windy City, and we have very windy and cold and maybe intimidating winters, but now is actually a beautiful and perfect season to visit. And so I put up a couple of these photos that I really enjoy, just of the colors changing even in the city itself. You don't think of our city as, you know, particularly fraught with nature, but here we have, you know, a lot of beautiful fall colors, and even in the downtown, where we have the statue of what we colloquially call the bean, the Skygate statue there. The colors really change beautifully around it. So worth visiting now, this time of year, before it does get very, very cold. Next slide, please. So this is an overview of our hospital and our section. We are just 5 of us in the section of colorectal surgery. You see myself there, and then my partners, Drs. Hurst, Hyman, Shogun, and Umansky. And, you know, the majority of our practice, frankly, at University of Chicago is actually IBD. But we do also see, you know, the general bread and butter, and then complex reoperative surgery and complex cancers. But we are in our city, I think, pretty well known for our IBD care. And then on the left here, you see a photo of where we are relative to that downtown I showed you. We're actually located on the south side of Chicago, and unique to most hospitals out there, we're actually just across the street from the university itself. So we're very, very close to the undergrad campus, and have a lot of access to the research that goes on in the undergrad and university in general. Next slide. So it's my honor to present our trainees and presenters tonight. I'll start with Dr. Lindsay Zhang, who's going to be presenting first. She is actually a brand new, newly matched colorectal surgery fellow who's going to be joining the WashU group next year, and we're very, very proud of her. She's currently our chief resident in general surgery. And then our current colorectal surgery fellow or resident, Dr. Markadis. She'll be presenting the second article. And then, as you perhaps heard if you tuned in early, we have a special guest today, Dr. John Alverdy, who I'll formally introduce a little bit later on. So I'm very honored to be moderating tonight and to join you. Next slide.
Fantastic. Thank you very much for that. So we have a poll question. the poll question is, do you test C-reactive protein levels in patients undergoing elective colorectal resections with an anastomosis and without diversion? The question is based on a study that we featured this month. I think Dr. Tom Reed was the senior author on this. If I remember correctly, it was from the Leahy Clinic, and I think Dr. Marcello is on the call, and I think he was part of this study too. So I'll be interested to see what people's practice is. And whilst we're filling those questions out, let's move on to the next slide, please. And so the first paper is titled, "Is same day and next day discharge after laparoscopic colectomy reasonable in selected patients?" The paper comes from the Mayo Clinic, with Dr. Nicholas McKenna being the first author, who has kindly joined us as well today. And so, Dr. Zhang, congratulations on the fellowship appointment. I think it sounds like it's a fantastic unit. We featured WashU, I think, about 18 months ago, and that was a great meeting for us. So please present the paper, and then we'll go from there.
Absolutely. Well, thank you, Dr. Bolshinsky, and thank you, Dr. Alverdy, for the introduction. I'm Lindsay, as was previously said. I'm one of the general surgery chief residents at the University of Chicago, and I'm just so pleased to be here to discuss this very interesting article from Dr. McKenna et al. On whether or not we should be discharging our patients on postoperative day 0 or postoperative day 1 after laparoscopic colectomy. We can go to the next slide. This is a really important topic to discuss. And I think it's because, in general, not just in our field, but in many surgical specialties, enhanced recovery pathways are becoming standard of care. This includes early diet initiation, multimodal pain regimens, expeditious ambulation, all of which have resulted in decreased length of stay for many patients. But now there's some recent data from France that suggests that we may be able to discharge our patients on the same day or next day of surgery, and that it could be safe for patients. But what we don't know in the US is whether or not we can safely apply this sort of early discharge in the same way and adopt it in the same way as other ERAS pathways. And we also don't know what patient and operative characteristics may make one eligible for early discharge, which is what this paper tries to answer. We can go to the next slide. So this is a retrospective cohort study using the ACS-NSQIP targeted colectomy participant user file. This is, of course, a large surgical database that uses trained abstractors to gather information from the medical record. And the targeted colectomy data set specifically has some data points that are only related to certain colon procedures. And so the patients in this study underwent a laparoscopic segmental colectomy with a primary anastomosis between 2012 and 2016. Both benign and malignant diseases were included, but patients were excluded if they were discharged after postoperative day 5, if they had any sort of OS to be created, if it was not elective, or if the patient was very sick, they were dependent on a ventilator or ASA class 5, and then any patient that had an in-hospital complication was excluded as well. So then those patients that were included and met inclusion criteria were then grouped into 3 different groups, whether they were discharged on postoperative day 0 or 1, in which case they were early discharge patients, if they went home on day 2, in which case they were intermediate discharge patients, or if they went home on days 3 to 5, and they were called standard discharge patients. The primary outcomes of the study, they looked at the rates of early readmission, meaning 7-day readmission, anastomotic leak, ileus, and then 30-day readmission between these 3 groups. Secondarily, they also created multivariate logistic regression models for each of these outcomes, readmission, leak, ileus, and then looked at which factors might be associated with an increased odds of these outcomes. We can go to the next slide. So they identified 35,620 patients for this study, which is a really large population. And among those patients, 906 patients were discharged on postoperative day 0 or 1, or were early discharge patients. 6,800 were intermediate discharge patients, and the vast majority of patients went home actually in the standard discharge group, meaning on days 3 to 5. If you look at table 3 from their paper, what you can see is in terms of differences between these 3 groups, early discharge patients were more commonly had benign neoplasm as the indication for their disease. They had fewer low pelvic anastomoses. So what you can see is the operative CPT code 44207. That's a coloproctostomy. And so there were fewer patients who had that sort of low pelvic anastomosis in the early discharge group. And then in general, they had a shorter operative time compared to intermediate and standard discharge patients. We can move to the next slide. The early admission rate, or the 7-day readmission rate within that early discharge group, was 2%. And when they looked at the patients who were readmitted compared to the ones who are not, it seemed that diabetes was the only factor that was associated with early readmission in the early discharge group. And then looking at the 30-day standard readmission, ileus and anastomotic leak, the rates were very similar between early, intermediate, and standard discharge groups. In the multivariate logistic regression models looking at leak, ileus, and readmission, early discharge as a factor was not associated with increased odds of the outcome compared to standard discharge. So in conclusion, this paper found, I think, a lot of interesting findings when you compared the patients who were discharged early compared to intermediate compared to standard. There was a low rate of readmission in the early discharge group, and they had very similar rates of ileus and anastomotic leak compared to the other patients. In terms of thinking of patient and operative factors that might predict success of early discharge, some of the characteristics they highlighted were patients who have minimal comorbidities, meaning non-diabetic patients, patients who are having a more proximal anastomosis, if the indication for the surgery is a benign neoplasm, so you sort of take out the factors associated with patients with cancer, and also some benign diseases like diverticulitis that we know can cause significant healing issues. And then in general, surgeries that were uncomplicated, which is translated by a shorter operative time. I think in terms of where to go for this paper are some things that we still need to think about. It's really unclear how to follow these patients that are discharged early. The paper from France that they cited had patients being seen like once or twice by call or in person every day after discharge, which probably wouldn't be feasible in many situations in our healthcare system. And then in this paper, just because of the limitations of ACS-NSQIP, we really don't know how those patients were followed or if they even were followed. And then lastly, I think the limitation of this study is this selection bias, because they tried to account for this by removing the in-hospital complications, meaning that we're just looking at patients who were discharged early or discharged late with no complications mucking up the reason for them staying. But regardless, there must have been a reason why the patients were discharged early or discharged later. And that's something we just don't know because of the way that we collect data from ACS-NSQIP. It could be that those patients who are discharged on day one were truly meeting all the criteria for discharge, having bowel function, everything that we would normally look for discharge, but we just don't know why they were sent home or why they were kept. And so I think in the future, we definitely have to consider those sort of limitations. And then lastly, I am really curious about the patients who had in-hospital complications or who stayed later than 5 days, because at the end of the day, I do think we're trying to predict how can we figure out if a patient is going to go home on day 1 or day 0 and be fine, and who's going to develop that in-hospital complication. So I think future studies would be interesting to see the differences between those patients to see if there's anything we can identify in terms of being predictive for success of early discharge. Thank you.
Thank you very much for that. That's an excellent summary. You raised some great points. Kinga, if possible, would you mind giving us a few of your comments on this?
Yeah, of course. So I thought this was a really nicely done study. Within the limitation of a retrospective study with a big database, I thought it was actually really beautifully done so that we could compare apples to apples here. So they excluded anyone with in-house complications. So these were folks who, if they had a complication, would have happened after discharge, whether they went home on day 0 or day 5. So there we can really compare if it's, the day of discharge that matters. But that being said, it does beg the question, why were some patients staying to day 5? Was it just bowel function, or were they staying for other reasons? Did they need placement for a rehab facility, for example? And what about the patients past day 5? Those patients were also excluded. So I may actually take advantage of the fact that Dr. McKenna is here and ask that question, why were the patients after day 5 excluded? But before that, I do have just a couple other points. And I entirely agree with Dr. Zhang that, you know, it would be interesting to actually compare those to patients who clearly, you know, failed ERAS or clearly had a complication, because I would be curious to know if there's something about those patients that we could predict on day 0 or day 1 to know if they're at risk of having that early complication. So I agree with Dr. Zhang's point on that. And then the last piece about, we really don't know whether the discharge was intentional or not. Did they just happen to have bowel function on day 0 and go home in sort of the standard ERAS fashion? And then just practically speaking to Dr. Zhang's point about this question of what follow-up protocols were there in place, or were there any? And we don't know that from NSQIP. But there are a lot of options for following up patients. Certainly that French study that was cited in this example was a very intense regimen. Patients were seen twice a day for 5 days and once a day for another 5 days. And really for our current workflow, that's a very resource intensive follow-up, but also for our patients, because we're asking them to come to the hospital twice a day for a number of days. And a lot of our patients have difficulty getting to and from the hospital to begin with. So for us, that type of follow-up wouldn't be realistic, but there are also other options. You know, we could include phone calls. There's apps to check patients' progress at home. They can send pictures of their wounds. So I would be curious to hear, you know, real world examples of how those patients are being followed in the, you know, US system. So I guess, Dr. Bolshinsky, I may ask you, should I ask Dr. Zhang a question, or can I send this to Dr. McKenna to give a comment since he's here?
I think that given that we're so fortunate to have him, we may as well make the most of the opportunity. Yeah.
Oh yeah, thanks for that nice summary of our paper. The reason we excluded people after day 5 was to try to eliminate this selection bias, because you're picking like the 2% of the healthiest patients around, so you could really prove on adjusted analysis that these people do better when day of discharge shouldn't really affect the ultimate outcome in terms of is it better or worse, because it's just a surrogate for a healthier patient. So we tried to remove that bias when we actually didn't even, because in some of the multivariable analyses, post-op day 0, 1 is like protective of anastomotic leak, which in and of itself being discharged early is not going to make you not leak if you're going to leak, beyond being you're a healthier patient that's eligible for day of discharge of 0 or 1. We started doing some day 0 and day 1 discharges after colectomies here. We already don't get any post-operative labs, so we don't do any kind of lab follow-up. We do a video visit with one of the APPs in our clinic on day 1 and 2, so the patient theoretically can go home the day after. We have them stay in town one night, and the day after that they can theoretically go home and then video call in, so there's no need for transportation to the hospital. I think the whole telemedicine has been one of the silver linings of the COVID pandemic, in that we finally have taken advantage of technology that's been around for a while to kind of optimize and facilitate patient care. And I think this paper we actually did before the pandemic, but I think since the pandemic, with restrictions on beds and operating rooms, et cetera, kind of across the country, people have really taken off with the same day discharge. We kind of view this as more of a proof of concept, that is it being done and can it be done safely? And I think the individual studies and institutions are going to be kind of the key to determine who is eligible and what sort of follow-up is best.
Thank you. Can I just ask a question in terms of what was your motivation to do a NSQIP study versus a retrospective analysis of your hospital database? And I particularly ask this because my biggest concern with sort of post-operative discharge 0 or 1 sort of time frame is the potential time to intervention that may be required for a sort of damage control procedure, where, you know, I understand that the risk of leak shouldn't be different, but the time to act on it, at least in where I work, will be significantly slower.
At the time we did the paper, we weren't doing any same day or next day discharges really. So there was very few within Mayo to even study. And we just saw NSQIP as the biggest vehicle to actually do some sort of proof of concept in the United States. Was kind of our rationale for using NSQIP. And as far as damage control and anastomotic leak, I think even in most studies, most people, unless they have a horrible anastomotic leak, are presenting kind of after the normal day of discharge, not where they have kind of a prolonged hospital course and you're going to scan them and find this leak before they symptomatically present if it's not within the first couple of days. So that was kind of our rationale.
Thank you. Dr. Marcello put in the chat, are we doing this for the patient, for us, or for the hospital? And I think it's a good point. I thought about that as well. Like, I understand the financial benefit or the throughput benefit in terms of getting patients in and out, but is there a patient measured benefit? Do they have less chest infections, less nosocomial infections, less DVTs? I don't know. I don't know if you've sort of, now that you've kind of adopted this in Mayo, whether you've noticed a benefit.
I think it's ultimately the patient's choice. Some patients don't want to be in the hospital, don't like to be in the hospital, so they'd rather recover at home, I think, and they're healthy and fit. And although it's reasonable, I think it's a good option for those patients. I think if the patient does not want to do that, then that's not the right patient to send home the same day or the next day without meeting standard criteria.
Yeah, and I think we see that in the ERAS pathway in general. You have a number of patients who are sort of nervous and resistant to the idea of going home early, particularly if they had surgery before ERAS where they were made NPO for days waiting for bowel function, and that's their expectation. So I agree with that it really has to be some degree of buy-in from the patient too.
Yes. Just for everyone, Dr. Silla put in a nice reference in the chat about same-day discharges. This is from Sages. I'll personally will have a look at it later, but thank you for that. Anyone else has any more questions about this paper or any points? Okay, in that case, thank you. And so the next paper is from Holland with Dr. Verdien being the first author. The paper is titled Visceral Fat and Anastomotic Leakage After Colon Cancer Surgery. Dr. Andrea Makardis is the presenter. So please start when you're ready. Thank you.
Thank you, Dr. Bolshinsky. Thank you to the DCR and the DCR Journal Club team for organizing this and for inviting us to participate. I'm excited to present this paper, which was published in DCR last year. So as we all know, anastomotic leak is one of the most worrisome complications after colon cancer surgery, and there are several known risk factors for anastomotic leak listed here. Visceral obesity, interestingly, recently emerged as a risk factor for postoperative complications from colon cancer surgery, and that's thought to be due to a chronic local and systemic inflammatory response. Interestingly, the association of visceral obesity and anastomotic leak specifically is unclear. There have been a few studies performed on this topic, but they have small number of patients in these studies. They use different cutoff values for visceral obesity. There's a low overall incidence of anastomotic leak in general. And the analysis of a lot of these papers use the analysis of all colorectal cancer resections as one group. This current study is the largest retrospective multicenter study on the association between visceral obesity and anastomotic leak. Next slide, please. It's a retrospective cohort study from prospectively collected data from 8 Dutch hospitals recorded in the Dutch surgical colorectal audit. The authors included all patients who underwent colon cancer surgery with primary anastomosis from 2011 to 2014, and their exclusion criteria was anyone who was missing clinical or scan data. They used preoperative CT scans for body composition analysis using this TomoVision Slice-O-Matic software, and they measured visceral fat, subcutaneous fat, and muscle fat at the level of L3, L4. The outcome variable that they were looking at was anastomotic leak requiring surgical intervention within the first 30 days postoperatively. They performed a logistic regression to assess the association between visceral fat and anastomotic leak. And the patient variables that were tested for possible confounding effects included age, male sex, BMI, skeletal fat, muscle fat, type of resection, ASA classification, and the patient's comorbidities and their Charlson Comorbidity Index. Next slide, please. There were 2,370 patients included, so a very large study. Of those patients, 85% underwent elective resection and 15% underwent acute emergency surgery. The association of visceral fat and anastomotic leak differed depending on the patient group. The overall leak rate was 6.9%, but it was higher in the acute setting compared to the elective as expected. Overall, patients with anastomotic leak were found to have more visceral fat compared to the patients that did not have anastomotic leak. And this association was held up when they looked at just the elective group, when they singled out just the patients that had elective resections. There was no association between visceral fat and anastomotic leak in the group of patients that had an acute resection. On univariable analysis, the factors that were associated with anastomotic leak overall, in the overall group were visceral fat, which had the strongest association with anastomotic leak with an odds ratio of 1.002, followed by ASA score, comorbidities, type of resection, with right colectomy having a lower leak rate than transverse or left colectomies. In the elective group, again, visceral fat had the strongest association with anastomotic leak with an odds ratio of 1.003, followed by BMI, male sex, and comorbidities. In the acute group, visceral fat was not associated with anastomotic leak. However, ASA score, pulmonary comorbidities, and type of resection were associated with a leak. They then performed an analysis correcting for confounders. And in that analysis, they found that visceral fat was independently associated with anastomotic leak only in the elective colon cancer resection group with a higher odds ratio of 1.026. There was no association in the overall or emergency colon resection groups. And for the elective colon cancer resections, visceral fat had the strongest association with an anastomotic leak of all the examined variables. Next slide, please. So in conclusion, visceral fat was significantly associated with anastomotic leak in elective colon cancer resections, but not in the emergency setting. Interestingly, the patients that had emergency surgery did have a lower overall visceral fat compared to those that underwent elective resection. And this effect remained after correction for the procedure performed, BMI, and sex. There was a wide range of visceral fat for a given BMI that they found, which can explain inconsistent reports of association between BMI and anastomotic leak that have been found in the past. And the higher visceral fat that was found in men, or the higher visceral fat in men that we know of, may kind of explain this association between male sex and anastomotic leak. Some of the limitations of this study are that it was a retrospective study. The data set seemed to miss some important known risk factors for anastomotic leak, including smoking, NSAIDs, and corticosteroid use. And they only studied cancer resections, no other colorectal resections. With that, I'm happy to take any questions or any questions for the panel.
Thank you very much. That's an excellent summary. Maybe Kinga, would you be happy to give a few comments, please? Thank you.
Yeah, absolutely. So, I think this study was very interesting and has a lot of positives. It's clearly a robust, reliable database. They include multiple sites and they have a huge collection of patients. And then statistically, they did a really thoughtful analysis of the confounders with a forward selection procedure. So that really was a very robust analysis. But I have a couple of perhaps criticisms that make this a little bit challenging to interpret. One is that their criteria for anastomotic leak is actually very strict. So they defined leak here as those requiring surgical reintervention within 30 days. And I suppose I didn't see, and correct me if this is something that I missed, but I didn't see anything like interventions by radiology or, leaks that were perhaps treated with antibiotics alone. And so that seemed like a rather high rate of leak considering how strict the criteria were. And And, the other criticism I have is a bit of the interpretation, which is that while it was very robustly statistically significant, the odds ratio for leak related to visceral fat was 1.026 with a tight but pretty tight confidence interval, but barely more than 1. So the effect size is actually really small for this association. So with that in mind, I have a question for Dr. Marcatus, which is that what is the clinical relevance of this? How is this going to change your practice, if at all?
Thank you, Dr. Alverdy. Yeah, that's something that I was definitely thinking about reading this paper. I think for me, these are cancer patients. These are still patients that we're going to operate on. I think it's still patients that, we're going to use our usual clinical and operative techniques. We're still going to leak test them. We're still going to oversew the anastomosis when we think it's appropriate. Still going to divert when we think it's clinically appropriate. I don't think that this would change my management for any of that. I think where it will kind of change my thought about these patients is in the post-operative period. So it this paper maybe kind of raises my antennas that these are patients that have a higher risk of leak. Maybe these aren't the patients that we would do the early discharge with. These are the patients that maybe if we think that something isn't quite right, we would scan them earlier or check labs more frequently on these patients. So I think it's most likely in the post-operative period where it's going to change my management.
Thank you for that. We have a few fantastic questions in the chat. I was hoping we can explore some of those. I think a comment from, not questions, comments from Dr. Gottsman was about sort of does the fat cause technical issues or metabolic issues? I mean, I personally, as I understand it, and the authors do highlight it to an extent, that there is a pro-inflammatory state associated with morbid obesity and metabolic syndrome. My personal view is that there are patients, super obese patients that do seem to be harder to clinically assess, whether it's because of a dampened metabolic response or just even physically, they're harder to examine. And I guess my question to both the panel and people on the call is whether you would do anything different in terms of your post-operative algorithm for these patients, like more likely to insert a drain, which is controversial in itself, of course, or, increase the reliance on a CRP or a routine post-operative CT scan. Does anyone have any views on this?
Well, sometimes when I'm thinking about whether to divert a patient, I'll take into account sort of standard things we think increase the leak rate, like is it a very low anastomosis, was the patient radiated? Maybe this could go into that bucket as another thing we take into account before we do an ileostomy.
Thank you. Speaking of ileostomies, I guess the more patients I treat, the more gray I see, not only kind of in my hair, but also in the decision-making. And I think with the super obese patients, in terms of diverting them for an elective colorectal resection, it's not without its difficulties and risks, both in the short term and the long term. And so people more likely to sort of oversew a stapled anastomosis or place in a mental flap? Is there any difference in sort of mitigating a potential leak, even if you don't kind of have any ability to prevent it? What do you think, Inga? Sorry, I'm picking on you as the host.
I was just thinking to myself, as you mentioned all those options, that if they were available to me, I would do them. It's in our group, we have quite a bit of variability in terms of who oversews those staple lines on a low anastomosis and who doesn't. Whether we use the no-mental pedicle flap, if I was concerned, I would certainly use all of the above, and I do. In terms of diversion, as you said, with the obese patients, the diversion's often harder, and that in and of itself causes potentially more complications. And so obviously this study was about cancer, but in my patient population with IBD, something Dr. Hyman and I talk about often is actually, in the pouch patients who are obese, omitting the diversion in that circumstance, because we tend to see more problems with that than, prevented complications from a leak. So I hope I answered that question.
I mean, one of those you can't get it wrong answers. Another comment was from Dr. Marcello about, do women with high visceral fat also have a higher leak rate? I have a hypothesis, and I'd be interested for people to critique it, whether the amount of testosterone predisposes people to have a distribution of visceral fat, because sometimes we see men with quite a significant sort of peritoneal adiposities as opposed to visceral fat, and we see women with a sort of a male distribution of fat, and it'll be interesting to see in this sort of in the PCOS population of female patients with polycystic ovarian issues, whether the distribution of fat would be more masculine, and maybe compare them to men and see what the anastomotic leaks would be with that. But maybe one day I'll find enough patients to compare that to. Well, I think we've discussed this quite well. Thanks everyone for commenting. We've got the poll now. Margaret, if you can share the results. So the result, I hope everyone can see the results. So the question was, do you test CRP levels in patients undergoing elective colorectal resections with anastomosis without a diverting ostomy? And I might use this opportunity to get Peter Marcello to comment about his views on this, and what is the practice in Leahy, given that the paper was from that institution, please.
Sure. Thanks very much. Appreciate the opportunity. So we found that on day 3, a CRP over 140 was somewhat predictive. So we're now doing daily nomograms to see if we can find a value on day 1 and day 2 to try to help further characterize patients who may be safer to leave sooner. If it's elevated, it doesn't mean they're leaking, but if it's low, it usually means they're not leaking. And I think we're all looking for things to help us earlier in their days. And so all I can say is that we're now using it on a daily basis, and I hope to come back with another study in a year or two to tell you whether a day 1 less than 100 means they're safe. And so high does not mean you're leaking, low means you're probably not leaking.
Thank you.
I would just say that, to echo Peter's point, there's been several meta-analyses that have been out in the last year, or even within the last 6 months, that have really driven home that message right there, that, depending on a lot of different factors, the high one, very high might be something, but it's probably better to be able to say that lower than the cutoffs, especially day through 5, that it is ruling it out rather than ruling it in, at least as it stands right now. And that's what the majority of the papers in the meta-analysis have shown.
Thank you. Okay, well, on that note, let's move on to the next segment. So we're very excited to have Dr. Alverdy, and I might ask Kinga if you volunteered to introduce him. You certainly know him better than me. If you're happy to introduce him, that would be fantastic. Thank you.
Yes, I would love to. So Dr. Alverdy is a beloved figure at University of Chicago. I say that as having been his trainee for years and years. We cherish his wisdom as a long-term researcher on the microbiome and anastomotic leak. And while he's not a colorectal surgeon per se, he's certainly been embraced by the colorectal community. And so I'm proud to introduce Dr. Alverdy. And I'm sure that he's going to wow you all as he has us for years.
Thank you very much, Kinga. It's a pleasure to be here, and I see so many familiar faces. Thank you again for inviting me. Thank to Dr. Hyman for asking me to do this and others. So I'm going to go ahead and share my screen if that's okay. All right. So I'm going to move this little piece over here. Okay. So again, thank you for the opportunity to speak to you today. Of course, I think this is really a fantastic discussion. And I put in the chat, you know, we got to be very careful about interpreting association with causation because many things are associated with leak, like you might say a elderly, complicated patient who has a difficult pelvis, whose BMI is 40, has a higher probability of leak, meaning let's say it's 20% or 15%, but the patient who's thin, who can go home the same day, everything goes well, has a 5%. But it doesn't really clarify the within group differences. For example, in the first case, why did 90 or 95% or 85% not leak? Well, they were also smokers and overweight and had a difficult pelvis and high visceral fat, but the majority did not leak. Yeah, but statistically, there was a higher probability of leak within that group. But the within group differences are very difficult to tweak out. And so it keeps leaving us with these odds ratios. And you know, it makes it very difficult as I'm listening to the discussion to know what's actionable and what's not actionable for the individual practitioners. So this is my disclosure, you know, started this company that is trying to make a drink that will prepare the bowel for surgery a little bit better than what we're using now. And again, you know, as many of you know and have heard similar lectures from me, I only have about 11 slides. I'll be done in about 10 minutes or less. But, you know, I study these problems at the molecular level because, you know, we all sleep with ghosts. We all have these patients that we remember leaking, and it's just a horrible thing. And, you know, people are talking about how we're the second victim. Surely the patient's the first victim. But I can just tell you, having gone around the country and gone around the world talking about an anastomotic leak, I mean, I'm like people's priest or their minister or their rabbi. They tell me these stories after I give my lecture, like, you're not going to believe this. I operated on the hospital president and things went badly. It was a perfect anastomosis. And I was up at the room when the residents called me 5 minutes afterwards, and patient spent 3 months in the ICU. I mean, from the highest quality institutions among some of the best surgeons that I'd let operate on me anytime. And so I think, you know, we sleep with ghosts, and, you know, in the words of Stevie Wonder, when you believe in things you don't understand, you know, that's when you suffer. And I think we all recognize that we think we know how to do an anastomosis well, but even when we do them well, they can leak. And again, you know, I trained in an era where every case was open and patients had NG tubes until they pooped. And now, you know, we do foregut surgery. I'll do a small bowel resection laparoscopically or robotically, and the patient will eat that evening and go home the next day. As we've heard today, patients can have a distal colorectal anastomosis and go home in a day, you know, if they're stratified properly, if they look good, if they're passing gas and doing well. So, you know, we've gone over the last 30 years so far, and yet we don't still understand that exact reason why patient A leaks and patient B doesn't. And, you know, our job is to try to get to zero. You know, I have a famous professor in Europe who said to me, I'd like to do a talk on anastomotic leak. I'd like to do a conference and say, how do we get to zero? You're like, well, nobody's going to have a zero leak rates. That's impossible. Well, let's talk about how we might get to zero. Because while SSI rates are at an all-time low, leak rates have kind of remained steady, especially as we're pushing the envelope to older, sicker patients, and we're doing things. We're doing pouches, you know, we're doing a lot of esophagectomies robotically. In fact, we did one today at the University of Chicago that was done through the chest and through the abdomen, all with the robot. That's a high-risk anastomosis in the chest, you know, obviously in the low colorectal area. So we need to think about that because this is our population. We're suffering through human progress. We have increasing antibiotic resistance in aging population. You know, I get my vegetables from in February in Chicago, as Vladimir talked about. You know, we have this beautiful Chicago, but it's really cold here in February. And, you know, vegetables come up from Chile and South America, and they're delicious. And, but what microbiome is in there? What antibiotics am I being exposed to? I don't know. We heard about obesity. So we still don't understand at the individual patient level why one person leaks and the other doesn't, even when you compare within groups. Sure, sets of patients, smokers, NSAID use, steroid use, immunocompromised, overweight, high visceral fat, yes, groups of patients can be said to have a higher probability of leak. But within that group, we still can't distinguish why one would leak and one doesn't. And most don't leak, which is good. And most don't get an infection. And most leaks, I think, under the hands of the people working here, are a surprise to many. They're not like, oh, I knew that patient was going to leak. Sometimes you close and you go, God, I hope this doesn't leak, you know. And we're learning that half the pathogens today that cause a surgical site infection, inclusive of an anastomotic leak, are resistant to the standard antibiotics chosen for prophylaxis. So the presumptive etiology is we did something wrong. There was a breach in technique, although there's no evidence for that. Some kind of intraoperative contamination event. And so all the current and future recommendations are more of the same. If some is good, more must be better. The problem is these are not evolutionarily stable strategies. They're not sustainable. We can't just say broader antibiotics. And every paper I've read says, you know, use imipenem, switch your cephalo du jour to a broader antibiotic, use more oral antibiotics, et cetera. And so the market assumption, you know, anyone you talk to out there says it's got to be mechanical. And everything's been tried, including glues and even ICG and Hanso versus magnets versus everting versus inverting. This is one of my favorite studies from, I think this is from Holland, where they put this crazy condom in the anastomosis. They stapled it in and said, this is definitely working. It doubled the anastomotic leak rate. It was published in the British Journal of Surgery. Because again, in our mindset, it must be mechanical. And there's no doubt technique is very important. No doubt you've got to do a good anastomosis. No doubt you have to get 2 good donuts. No doubt you should do a leak test. No doubt blood supply is important. But even when all that is done, and I'm assuming it's done by this group especially, in the most technically adequate way people can leak. So, you know, we came up with this alternative hypothesis that perhaps it has something to do with bacteria. And this is basically 30 years of working in another sphere of studying this at the molecular level, where we showed that inflammatory signals themselves can literally activate bacteria. They're conditionally activated to express a higher state of virulence, where they increase their adherence capacity and they can produce these collagenolitic enzymes, which then activate protease. And remember that protease activity is the hallmark of all abnormal healing. Remember that from your basic biochemistry, that collagen strength, it's in the submucosa, it's a function of remodeling. Yes, there's synthesis and degradation, synthesis, degradation, breakdown to get those strong disulfide bridges in there. And that's why MMP9s are secreted by inflammatory cells to break down the collagen so that you remodel it and make it stronger. And so, you know, how that plays out in real time in a given anastomosis is not clear. People have tried in IBD anti-MMP9 inhibitors, antibodies. It didn't work. Now, how it's given systemically, does it go to the right place, et cetera? It's complicated to just say, oh, it's MMP9's protease, let's stop protease activity. No, you need protease activity, but just the right amount at the right time. So we did this study that was published in Science Translational Medicine, and we really did, Ben Shogan and others really did a fantastic job, because we had strains, Pseudomonas and Ephicalis, where we disabled the collagenase gene in the bacteria. And when we reintroduced that, it caused no leak in the rats in this case. And there may be a blind spot that we have because these organisms, which at least in our animal models are highly collagenolithic and break things down, are the two most common organisms that you see when you percutaneously drain a leak and culture it. And so, are we covering these? And how is it that we give, and we do this at the University of Chicago, we have a drop-down menu. Everybody gets the same antibiotics. And we certainly know not everybody's microbiology is equal. We talk about obese patients. Well, it's been shown that obese patients harbor higher antimicrobial resistance genes among their microbiota than non-obese people. Well, should we be giving them different antibiotics? I don't know. What's that? They're anastomosis. I'll talk about that in a minute. But these organisms are becoming more resistant. So when Christy Guyton, who's a colorectal surgeon now at the University of Iowa, she, was again, worked with Dr. Hyman, and worked with me in the lab and others. She spent her 2 years in the lab with us, and they did this fantastic study where they literally looked at patients in the operating room, looked at the anastomosis, did their leak test, but we put 50 mLs around the anastomosis and then collected the effluent and did proteomics, metabolomics, microbiome studies. We then looked again at 2 weeks, at 3 days, right before the patient was being discharged, even if they looked perfectly fine. We looked again to see what it looked like. And then when they came back in 2 weeks for a follow-up check, we looked again. And you'd say, well, that's excessive. You don't need to look that many times. Can't you go by CRP, or can't you go by, a physical exam, or if the patient's having pain, or maybe you should do a CAT scan. But this actually was quite interesting because there were several patients. Dr. Hyman did all these endoscopies himself. There were several patients when we looked in there, and these were low colorectal anastomoses. It literally took 5 minutes with just a little lidocaine gel. They were relieved to know things were healing well. They weren't mad at us. They were actually relieved because in the consent form, you tell them, oh, if you leak, you might end up in the ICU. It could be a disaster. You have to go back to the operating room. And so it was really interesting just to do this. And we only did it in 10 patients. But, my opinion is that we need to characterize in dense molecular detail the natural history of anastomotic healing in humans. It is unknown. How can that be? Well, you'd have to look in there serially and do some molecular analysis to know. So here are 2 patients. And again, this study was not powered to be predictive. But as you might imagine, as you can see there in the operating room, everything looks perfect. 2 donuts, the leak test is negative, everything looks well perfused, the ring is intact. But boy, when you look, on post-op day 3 and 5, those anastomoses are pretty angry looking, as you might expect, right? It's not going to look the same as when you first did it. And most people don't look, and you look at the top one, but to me, the bottom one looks worse, but I'll be willing to listen to whatever anybody has to say. And the top patient had these worrisome areas for, some ischemia or necrosis. But the top patient had a high growth of collagenase producing E. fecalis in the anastomotic lavage fluid. This patient did not. And this patient came back on post-op day 24, was discharged home, was doing fine, and came back with that big abscess. Whereas this patient went on to heal fully when we looked there on SES3, serial endoscopic surveillance day 3. And, what governs going from looking bad to perfect healing versus looking bad to leak? I don't know. There's probably a lot of factors in there. Do bacteria play a role? We think so. Are they the only thing that plays a role? Probably not. So this is my last slide. And I just think that we need to know this. If we're thinking about how to get to 0, we need to know how things heal over time. We need to look. And you might say, look, who cares? And having traveled around the world giving this talk or similar talks, a lot of surgeons say to me, look, we know all anastomoses leak a little. Nothing's airtight. Maybe in the operating room it's airtight, but not 3 or 4 days later. But the body seals the thing. And as long as they seal and the patient's asymptomatic, we don't need to know this. But if you don't know this, how are you going to know this? And again, you might say, well, not everything heals perfectly every time. As long as things seal and the patient's asymptomatic, let's say the CRP level's okay, we don't need to know this. But if you don't know this, how are you going to prevent this? And you just say, well, you know, our leak rates are down to 5–6%. You just got to avoid this idea of failure to rescue. You know, there's, as was mentioned on this call, there's telemedicine now. There's follow-up phone calls by our nurses, early CT scanning, CRP levels, percutaneous drain. You can divert if you're worried. But again, I think if we want to get to why these things happen, and Ben Shogan, you know, who was in my lab for 2 years, is now working with Kinga and Neil Hyman and others in our colorectal section, is looking at how bacteria cause cancer recurrence. Shed cancer cells intermix with bacteria in the lumen in these patients that can change the phenotype of those shed cancer cells. And today, I hope not in the hands of the people on this call, but today about 1,500 people in a year in the United States will die of an anastomotic leak. So I think there's a lot to learn. And, you know, we hope that we can do studies in with a little bit more molecular detail, not just observational studies, to understand some of these things. And I will stop there and answer any questions if anybody has any.
Thank you, Dr. Alverdy. I had a few questions, but they kind of paled into insignificance given that you've mentioned most of the things and I think wonderfully tied in what we've discussed in the previous two articles. I guess the only thing I want to know your opinion about is there's a number of patients that we see who've had multiple surgeries in the past, I guess particularly in your institution, the IBD patients, that seem to have a higher risk of C. diff infection, say after a reversal of ileostomy or something like this. What is your take on these patients with a perceived exposure to maybe, you know, hospital-acquired organisms or you know, excess antibiotics? How do you think about those?
Yeah, you know, I get a lot of questions like what bowel prep should we use? Should we add an anti-enterococcal antibiotic? And we think the answer to that is to develop what I call bowel prep 2.0, a new bowel prep that somehow doesn't eliminate all the bacteria, but somehow contains their harmfulness, their virulence, that can suppress their ability to make these bad enzymes. And through the course of surgery, not just take it before, but during, immediately after surgery, maybe even when they go home. And we're working on that to develop that solution. More antibiotics, as you've seen from the COVID epidemic and everything else, more antibiotics is a problem because it's just going to lead to more resistance. And, you know, at the same time that surgeons are seeing broader antibiotic coverage actually decreases your infection rates, and it does, but there's a trade-off there, right? At the same time, surgeons are doing that in pancreatic duodenectomy and colon surgery and other surgeries. The ID people are telling us stewardship, reduce your antibiotic use. So it's a weird trade-off and a balance we have going here. I often get asked, can we screen these patients? And maybe that's your point, Vladimir. You know, can you look at it like a high-risk patient? This patient has IBD, let's say. They're going to have a pouch. They're obese. They've been on multiple antibiotics. They've taken a bunch of biologics. You look at them and go, they're an accident waiting to happen and they're going to leak. Maybe I should know what's in their microbiome. Can I be more prescriptive in my antibiotic coverage? And the answer is yes. You could survey them, nares, mouth, stool sample, but it's very labor intensive. And so what we're trying to develop is a screening tool where you might be able to take that patient, do a nasal swab, a rectal swab, and say, okay, let's make some changes. And one of those changes can be a dietary change to a plant-based high fiber diet for just a week. It will turn things around almost immediately. If they have a multi-drug resistant organism like a Pseudomonas or a Strenotrophomonas or something very bad, we might consider decontaminating them of that. And then to your point about C. diff, if they're C. diff carriers, that is a little unnerving and a little bit worrisome that we're going to operate on this patient, close their ileostomy, and then they're going to end up with bad colitis. Even in the ileum, if they have no colon left in their body, can still cause ileitis, pretty severe inflammatory reaction in the pouch or in the ileum that has become colonized. So yes, I think, but it's not readily available. It's not something done routinely. And as you can see, when you even though a C-reactive protein is available today in a lot of institutions, you can see from your poll, most of us don't order it. You're like, well, but it's predictive. And I think Scott made a good point. When it's negative, it's very useful. And it might be very useful to know your patient does not have C. diff. They do not have enterococcal collagenase producing bacteria. They do not have Strenotrophomonas. It'd be useful to know that, but it's not something that we deploy today.
Thank you. Again, I think there was a few questions in the chat, but I think you've covered those by a comprehensive answer. Thank you very much for your time. I don't know if anyone else has any questions before we finish up, but I think it's been fantastic. And I'm very fortunate that we've recorded this, so it is available on the YouTube channel. And I think it's very thought-provoking, because unfortunately everyone's partners seem to get an anastomotic leak. We don't, but the partners do. So next month we have a new feature. We're having a debate, and it is about anastomosis as well. I guess in colorectal, everything comes down to the joint. And so we're going to be debating the pros and cons of the ConOS anastomosis, and we have 6 excellent panel members and 3 judges. And I am honestly and genuinely looking forward to it. I think it'll be a fantastic event, and hopefully it'll be one that we will repeat next year. There's just one hand raised, I think, from Dr. Marcello.
Well, first, I just want to say, Lindsay, congratulations. Welcome to the family.
Thank you so much.
You're going to make it. Yeah, that's first and foremost. John, I got to ask you this, though. I wanted to hear you. I love every time you talk. It's so stimulating. Can a patient have a species of Enterococcus or Pseudomonas that has a high level of collagenase, and then at a later time have the same species has a low level? Or do you the species stays the same, or does it vary?
No, it does vary. That's a really good question. No, it definitely varies, and it's highly diet dependent. It's highly dependent on who the neighbors are, because remember, most bacteria live in these giant ecosystems where they keep each other in check. So it's the presence of the normal bacteria under normal circumstances in you and I that keep the enterococci at bay. Remember, the anaerobes are at 10 to the 12, 10 to the 14. And the aerobes, facultative aerobes like Enterococcus, Pseudomonas, the gram-negatives that cause all the problems that we see, they're like 10.6, 10.7. We're talking orders of magnitude difference. So when the good guys outnumber the bad guys, and they secrete molecules that suppress the quorum-sensing genes in these enterococci, they're at bay, they're held in check. So it's a really good point. What happens pre-op when a person's eating really badly and they're obese? and they've taken antibiotics and they've, taken clindamycin for their teeth cleaning or whatever. And then we operate on them. And then unfortunately, they're NPO for 3 days. You're like, why can't I feed them? Well, they have a little ileus, they're burping, I don't want to feed them. And then we're able to feed them, their ileus resolves, and then they start eating again and they repopulate. And we give them antibiotics in a bowel. Our idea is we need to see that dynamic shift, to your very point.
All right. Well, again, thank you all very much. Very grateful for the University of Chicago. Thanks everyone on the call. Hope to see all of you next month with your friends and colleagues.
Thank you.
Have a good rest of your day.
Good night.
Great job, DCR team. Excellent work. Great production.
Great job.